Thank you for joining us. We are here for the fourth Community Coalition Kickoff call, and my name is Victoria Cash, and I'm the quality lead for the IPRO ESRD program. So a couple of meeting reminders, you are all on mute. We have a lot of people attending today. So to prevent background noise, we do ask that you use the chat feature, and just giving you some idea of where you can find that and chat to all participants. And there's the team of us try to answer questions as they come in through that chat panel. So please feel free to send those in when you have them, and we will work our best to respond to all questions in a timely fashion. The other piece is if we do have an opportunity to unmute you and get questions, which may more likely happen in the breakout sessions, I just want to show you how to unmute your line. You'll have a little red, hashed out microphone there that you can use, and you should unclick that and make sure your headset's on or whatever microphone that you're using so that you can, share whatever input or questions that you have. And this is just a little bit of information about IPRO as a system of ESRD networks. So we actually work with 4 different regions of the country. And one of those regions is the Network 1 region, which is the 6 states of the New England area that has about 15,000 dialysis patients and 200 facilities, ESRD dialysis facilities, as well as 15 transplant centers. And then we also work with Network 2, and that has above 28,000 going on 29,000 patients, 343 dialysis facilities, 13 transplant centers. In Ohio, Kentucky, and Indiana, we are in Network 9, which has 32,000 dialysis patients and 645 facilities, 14 transplant centers, and then Network 6, which is North Carolina, South Carolina, and Georgia, which has 50,000, our biggest ESRD network, 810 facilities and 10 transplant programs. So all told, there's about 126,000 patients that are in the program, over 2,000 facilities, and 53 transplant centers that we work with on our team to share the CMS goals and vision and work on the quality improvement that they see necessary to help patients live their best life with kidney disease. So why are you here today? You're here today because, as a group of networks, we are asked to work with facilities who can help us and help themselves improve their outcomes through solid quality improvement practices. So we look to form community coalitions, which is what you have been asked to join. That work is something that CMS guides us to do. When we as a group of networks assemble data and look at it, we pick some facilities and we work with advisory committee members from within your community. So these may be physicians, nurses, social workers, any kind of specialist in the areas that we're focused on that can give us advice and assistance with how to work on improvement in the different quality areas. They'll look to, we provide them data, they help us pick facilities, they look at some best practices, and really give us some overall structure and make recommendations. From that information, then we form a list of facilities that we work with. You may not be facilities that are challenged. You may be performing very well in this quality outcome or middle of the road, or you may be struggling. You may have some barriers. We try to put a variety of different facilities into the community coalition and work with you to figure out what could you do to improve, or what barrier could you overcome to reach a new level of performance, and then how could you test those ideas and work through a plan, do, study, act cycle to see if that change would make a difference. So we have all asked you, identified you in the community as one of these types of facilities that we would like to work with in this RCA process, where we do the root cause analysis to find out what that kind of critical barrier is that you want to work on, and then go forward to a plan, do, study, act process. And this group of facilities is known as our community coalition, and I'm sure you received a letter indicating that you were going to be part of the community coalition to work on different outcomes that CMS has requested be done with the facilities. So, when we do this, we look to learn from what you're overcoming, the barriers that you suggest, and how you work on that. A plan, do, study, act cycle, very simply take some action or actions that you think would help, maybe an increased focus and level of education for staff and patients on a particular topic that you routinely apply, and then you see whether that education and support then leads to a different behavior, and maybe more patients are considering transplant or home or something of that nature. But we learn from the tools and resources that you use and put in place, and we watch those outcomes and see if there's actually a change and more of the positive indicators are shown from the work that you're doing. That then helps us to share that with the whole community. And in the end of the day, what we're really trying to do is improve practices to achieve quality of care. So that will always affect our patients and make things better. And I know, and we all know, at the network, we are also dealing with less staff, and we all know that everybody is struggling with staffing problems and issues that make it hard beyond the day-to-day practice in your clinic. But at the end of the day, quality of life for these patients, I think, is why we've all entered this field. And so going beyond just delivery of the treatment, but also improving their quality of life should be our main aim. And hopefully with a team and some effort, we can get over this hump of staffing and get to, really working together on some great practices for everybody to have a good quality of life. So the RCA, we sent out to you links to do this. When you do a root cause analysis, we really ask that you dig down, not just stop with, oh, patients aren't interested. Well, why are they not interested? What is causing that lack of interest? Is it a culture problem in the facility where people don't really, have a good understanding or buy into a particular practice? Is it the patients are fearful? Do they have other challenges that they're working through that we need to remove some of those challenges? So really dig into the RCA and try to figure out, like, what is the source of that lack of interest or fear, and try to figure out one or two things. You don't have to make your plan, do, study, act process a complete revamp of what you do at your facility, but maybe it's just trying one or two extra things that you think might help. And when you do a plan, do, study, act cycle, you put those in place, you watch how it's going, you see if there's more patients interested in making a change, or maybe they're not going to the hospital so much, or it's really helping prevent a hospitalization. And that way you can say, oh, this is working. We're going to do it more thoroughly, more of it. And, that's when you go into the act process. Sometimes those things don't happen. Sometimes those are, sometimes you find out that whatever you put in place is not effective. So we ask you to circle back and think about what you could do a little differently again, and check it out and see if it works. We are going to stay connected with you for a period of that 6 months, very closely, kind of working through, okay, what's your plan? What are you going to do to enact it? How are you watching the results? Is it successful or not? So we'll continue some communications and providing resources and trying to help you through that process. And this is a classic quality improvement process. So we're really trying to help, this is how you should start every day. And in simple life, many people do this just as a natural part. What's the barrier? How are we going to do something to improve it? And not thinking, your own self-conceived ideas of barriers, but really studying and saying, oh, what would really change this? Not what I believe is the problem, but maybe what a team believes and what patients may tell you, things of that nature. Then we'll really watch the community coalition facilities and stay in contact with you probably for a whole year. We'd like to know what's happening. We have seen in our other coalition work now, we've been through 3 successive rounds of this. You are the 4th round, that facilities do start to improve in their outcomes. We're starting to watch those outcomes come in and get better. So this does really help. So we will stay connected with you and hope that, through this kind of 12 months of learning and improvement, you get something out of that you can apply, and you continue to apply that to different areas you're looking to grow and improve in your work. And this just, is a depiction of us working with you. So this slide shows that we did have a community coalition that ended in October, and you're the new group that we've made contact with, and we're kicking off right now in October for an effective start in November 1. You're our community coalition 4. And then these slides show you the areas that CMS is asking that all ESRD facilities focus to improve on. So one of the areas is focused on behavioral health, and in particular, talking about screening for depression, and then not only screening, but once you screen and you have a positive result, do you send the patient on for treatment? Do they want to go on? What happens with that patient? So, it's a review of getting everybody screened at your facility, but also then what's the follow through and help for somebody who comes back with a positive depression screening. Goal 2 is really focused on a subset of a population. So this is working with nursing home patients because they're a very vulnerable population, and CMS would like us to make sure that there's not increased infection because many of those patients have to live the rest of their life with a catheter. And some of those patients are in with PD accesses too. So just to make sure that they don't get a healthcare acquired infection, during that very vulnerable state of their life. So this is an area that we're focusing on. In goal 3, it's really a massive goal area. It includes lots of things. CMS bucketed into high cost care and complex conditions, but it talks to all of our trying to get more patients on a home modality, trying to get patients education and to transplant and on wait list, as well as, preventing the spread of disease. In particular, COVID-19 really ravished the ESRD population. So there's still a focus on COVID-19 with all the new variants, but just overall decreasing hospitalizations and decreasing the spread of infection in patients, which falls heavily on vaccination. And I know we've all grown a little tired of vaccination, but it's our only tool to prevent the spread of disease. And for, this population that is so at risk, it is so important that whatever your beliefs are, that you believe for these people, it's important to maintain their best possible health with potential vaccination. And then we have goal 4, which is focused on cutting down the use of acute care services. So we know that patients who are frequently hospitalized, going to ED visits, they suffer a lot of sequelae. It is not a good thing for patients who have to keep going back in. Shows as there's a broken system there, and they're not getting an overall resolution for their issues, and they're using a system which is very expensive for their care, as well as doesn't offer that continuity. So we really want to reduce all this use of hospitalizations and 30-day readmissions when we can, and ED visits and things of that nature. So this is a focus to try to get that. So we don't have people that use acute services as their normal care, that it really is kind of emergency and, something that needs those services ongoing, and they don't get readmitted for things that they could have had finally cured in the hospital and then followed outpatient. And then in the last area, this is again circling back to the nursing home population. And another marker of good care in that population is to prevent unnecessary blood transfusions, so that we're really watching this group, in their vulnerable state and making sure they have good iron stores and blood stimulating agents so that they can, not avoid unnecessary transfusions when able. And the one we don't have, external numbers for, but we know is very, very important, and they don't list them per se as a goal in our work, but it is actually a quality improvement factor, is getting patients and families involved, or any caregiver involved in their care. And there's a growing body of research that really shows patients who are activated, involved, or have a supportive care network that's activated and involved will make good choices for themselves. They'll live longer, healthier lives. And that is the key to the success there. How do we measure that? How do we say, oh, we've got patients really involved and invested? Well, CMS has put 3 metrics out there. They would like to see some patients at your facility talking with your leadership team about quality improvement. So, being part of that quality assurance and performance improvement process that you have in your clinic, and taking it from a patient set of eyes.
The ship sails.
We also have a number of facilities,
people have
ways
rights.
we want to measure it with life plan development. So patients, we often do care plans that talk about control of phosphorus or weight gains or blood pressure. That isn't somebody's life plan. That's, a particular instance that they're dealing with medically. what we'd like to do is also have a plan that talks about, okay, if you could get this much better, what would you be able to do? Would you be able to go travel and see a grandchild? Would you be able to lose weight to get to a transplant? Would you be, so bigger life plans that really look to the overall goals for people to live productive and happy lives. And then lastly, we're trying to grow the amount of people that are peer mentors for patients. So there is no one better than another patient who is going through the same situation or has to talk to patients who are struggling. They're in their shoes. They know what's going on. They know what some of the simplest barriers that patients face that we don't see. Maybe we're dealing with other things. A patient will know for that patient, and they'll be able to kind of talk them through the process and help them in their decision making. So we're trying to grow the amount of peer mentors that are out there to help patients as they work through transitioning to end-stage renal disease, considering other modalities, et cetera, in their life. So these are not listed as goals, but we definitely have metrics and numbers and ways that we're trying to increase and improve that involvement. This is just a slide I threw in to kind of talk about that Plan, Do, Study, Act, give you, an example of that. So let's say, in hospitalizations, you say, okay, we don't have anybody who looks at how people transition out of the hospital. So we're going to start that. That seems to be something that's going to help because we don't, we're not looking at people's medications and we're not checking some of these things that are very important when they come back. So then, you put that in place and they do start reviewing the patients upon return, and they do all the necessary pieces to make sure that the patient understands and is, able to live without a hospitalization at home. And you continue this for 4 months, and the positive result is that you see less patients entering the hospital. So that kind of shows you, a shortened version, but what the Plan, Do, Study, Act is like. And this is what we hope that you come up with a solution, a change, an intervention you're going to put in place and monitor through to see if it's making a change. So, the things you should be asking yourself, as you get ready to talk with your quality leads is, what kind of interventions, what should we focus on in the area that's been identified? How soon can we put those in place? What can we do to get that working? What is the measurement outcome? Some things are very long-term. You may not be able to say, oh, these 6 patients got on the wait list. It takes a long time to get on the wait list. But do you have more referrals going to the transplant center? If you have more referrals, then you're more likely going to have more people ending up on the wait list. So pick some, intermediate things that you can measure to say, oh, this is looking like it's working. We had 3 more people go to the transplant center than we did before. And, know some of your unforeseen barriers and keep talking about those things with your quality team. And we always like to, mention, and I think it's really, really important, is the more you look at, the more you see it, the more you talk about it, the more you focus on it. So visual management, such a key part and such an easy way to keep quality processes moving. So this is an example of some of the huddle boards that people have shared with us where they have data out there. They pull their team in, they talk about what's going on, they shout out any particular successes, what they're working on. They can have patients. We've heard people have patients come down the hall and talk about the huddle board and what's working. So it really can be a quick and decisive discussion and really keeps people focused on the prize. And then, we also have all the IPRO Learn interventions that we have out there every month. We are going to share with you all the work that we're doing and all the ideas that we have about, did you see this? Did you read that? Do you think this would be helpful? Because all these areas are important for us to keep focused on. And what we ask that you do is maybe work out a delegation system within your facility. So there's a couple people looking at the different IPRO Learn interventions, so it's not overwhelming for any one person. And if anything really hits home, that you guys are having group discussions about those. And then, the other thing we like to share with you is, where are you at? I know most of you have corporate goals that you're given, and you have probably a list of what you've done and what you've achieved. And hopefully that our goals are something in line with that, because you're probably all heading for more transplants and more home placements. So, this is something where you can say, here's what we're doing in the network view of things, here's how we're doing corporate, and you can keep working to succeed at those numbers. We feel like giving you, definite numbers to improve. It gives you a goal, and everybody knows what they're shooting for. So now I want to talk a little bit about IPRO Learn because it is where we house all of our quality improvement information. So it is kind of our one-stop shop for sharing quality improvement information, as well as having you guys interact with us about that. So this is your login. Everybody should have their username, which is basically your facility CCN, and then we have a one password which we share with every facility. Anybody can use that. You can post that in a little clipboard by your group shared PC, whatever. Anyone can go in and use that to look at all the things in IPRO Learn and take activities and do things of that nature. So it's meant for all in and can be publicly posted to access the IPRO Learn. And we did move over to a new website location. If you go to the old one, you'll still be redirected, but this is the new website location. So when you land in IPRO Learn, what do you have the choice of doing? Well, we're very happy to offer CEs. These are free CEs. Right now, we don't have them for social workers. We are trying to work on that. It's a much more complicated process, but we are putting some effort forward to see what we can do to get social worker continuing education too. So we hear you guys. But right now we do have it for RNs, LPNs, dietitians, and dialysis techs. If you want to get a CE in IPRO Learn, you have to have your own private account because we cannot attribute a CE to a facility. So you have to create an account. It's just like having an account with anything else. You'll have to have your own login and your password. But you can go in, you can take any of the CE courses annually and claim those CEs. You'll get sent a certificate via your email, and you can use those for any kind of your recertification, etc. Now, the other area that you can go into then is the collaborative area, and that's what has featured here in the red frame, and that's where all the activities are going to be for dialysis patients, for dialysis staff, that you can go in and look at the announcements and the to-do activities. We are building a patient representative area. It does have some information in it now, but that's being built slowly. And we're working more one-on-one with patients because we're finding they like to do it as an in-person meeting more than going in IPRO Learn and taking the courses. So we're trying to blend that so we get all the patients involved. And then, when you pick the collaborative area and you go in, you're going to see this landing page. So we always try to keep up to date recent announcements and what's new. There might be programs here that other outside venues are offering. We put in CMS announcements about QIP scores being ready, everything that we can think of. We keep it timely. We try to bring it up as soon as it's available and take down postings that are not current. So you can keep, as a way to keep in touch of what's going on, you can browse that area. And then we have the list of to-do required activities, which they are each month. We do assign a group of activities in each quality improvement area for people to look at. We're mostly trying to stimulate your thoughts and ideas about how to improve and give you maybe resources that are not available to you from other sources or fill a void that you don't have a resource in. We like to hear whether you think that would be valuable, how you would use it, how many patients would you think would benefit from it, so that we can understand whether these tools are good for the community or not. And we do literally, if we get a tool that we put out there and 800-900 of you respond and say, it's not that great, this doesn't really help, patients have a barrier. One tool I think we were trying to promote was very computer-based, and we heard from many of you that patients just could not do the whole computer thing. So it's not something that we frequently promote anymore because we know it's still part of our toolkit, but we know that it may be more difficult for patients to use just based on the feedback you shared. So we react to everything that you tell us. If you tell us there's a void, we try to make resources to fill that void. We just are recently releasing stigma resources because one of the things we heard in depression was there's no resources about the stigma factor and how that affects people talking about their depression. So we've worked on that. We've worked with our patient groups, and we've created stigma resources that now you can use to help open up the conversation about depression at your facilities. So we really use the information you share with us and are really hopeful that it helps you to just kind of bring new ideas and light to your quality improvement work. And then in the bottom, all of these tools that are vetted and come from, national sources as well as our own, we have organized into a toolkit. So if you're ever wanting to just think, how can I improve vaccinations? You can click into that toolkit and find everything we possibly have put in there. It's not branded, no branded resources, but we will have everything that's from the CDC, NHSN, all the, nationally vetted resources there, as well as our own and other things that we can share with you to improve vaccinations. So we hope you use it for that. This is just a look of when you drill into a page. So this is going into the toolkit. You can see the table of contents here with all the different offerings that we have. And you can see, how you can go here and maybe you want to watch this video or have your staff watch this video that is a general introduction to transplant to understand what patients will go through. And then we usually will ask you to answer some questions and tell us what you thought of that material and will it be helpful, things of that nature. And this is another area that you can also get some help from and an area where you can, get guidance with the tickets. So we have a help desk ticket system. We do use it for quality questions as well as data questions. The reason the help desk is very good to use is it's always attended. And we do have timing, metrics on it so that we get back to those tickets. Many times, I can tell you today that we have sat on calls since 1 o'clock this afternoon. So if anyone's called us, we have not been able to return that call for 4 hours. And then we'll try to call you tomorrow and you won't be in office. And that's when the phone tag all starts going, right? So the help desk tickets really are very, very important way because they're always there. We can check them at the end of the day, the beginning of the day, whenever, and we can, try to get back to you with answers or support. Also in the help desk area, there is this knowledge base portal. This is a lot about some of the data systems and different information that you need to understand when entering quality improvement data, etc. So you can always use this portal to answer questions for yourself or look things up for NHSN or EQRS, things of that nature. So I'm going to turn it over to Danielle Andrews, and she's just going to do a little overview of health equity because that has become a real major focus for our work. Unless there's any questions, Laura, I have not been watching the chat or anybody else in the group. Has anyone seen a question come through chat that I should attend to?
No questions.
Yeah. Okay, thank you. All right, so Danielle, do you want to take it from here?
Sure. Do you want to pass me? Should I make myself the presenter?
I can just move the slides, Danielle.
Okay. So I'm going to talk to you a little bit about health equity. Next slide. So let's talk about what health equity is. When health is equitable, that means that it's an even playing field. That means that there are no barriers that are going to inhibit or restrict a person from receiving their overall quality of care or their highest quality of care, regardless of their socioeconomic status, regardless of where they live, regardless of their sex, gender, or their sexual identity. So when we have health inequalities, there are going to be differences in health statuses. There's going to be differences in the distribution of resources. There are going to be differences in social conditions, and all of these are going to impact how accessible healthcare is to a lot of individuals. So depending on your neighborhood, your physical environment, your healthcare, income and wealth distribution, education is really going to determine your access to healthcare. Next slide. So when we're talking about social determinants of health, these are factors in the environment where people are born, live, learn, work, play, worship, and age. An individual's overall health and well-being is affected by access to equitable healthcare. However, their general environment, community, interpersonal relationships, and education are also the fundamental drivers of an individual's overall health. So in order to make sure that these individuals are receiving equitable health care, we have to ensure that their housing is okay and safe. They have access to employment that can make sure that they have food security, that can cover their bills to make sure that they have stability. We have to make sure that they have access to healthcare systems and effective healthcare professionals. We have to kind of balance out income and wealth. Also talk about physical environment and environmental racism, as well as access to public safety. And we have to ensure that they have a safe and supportive social environment, as well as access to equitable education. Next slide. So we did a health equities barrier identification survey that we sent out to all 4 networks, and we had about an 86% response rate. So from that survey, we found out that 26% of patients do not have a primary care provider. We found out that 18% of our facilities are located in food deserts. And then we found out from there that 85% of facilities stated that financial reasons is one of the biggest barriers to helping patients follow the renal, diabetic, or cardiovascular prescribed diets. In terms of transplant, 61% of facilities stated that transportation was one of the biggest barriers. Patients are struggling to find transportation from their appointments. Patients are struggling to find transportation to even maintain their dialysis status to make them compliant with treatment. Also, we also found that patients have limited to no dental coverage, and that is prohibiting them from completing the full transplant process. And then in terms of home therapy, 71% stated that patients tend to have limited space in terms of holding home therapy supplies, and then generally that their overall environment is just not conducive to them having home therapy or doing home therapy. And then in terms of vaccination, 77% of facilities said their patients have a general mistrust in the healthcare system or have faced medical racism. Next slide. So when we're talking about identifying health equities, it's important to remember that health equity does not solely revolve or are not solely associated with race, ethnicity, and disenfranchisement issues. Any barrier that inhibits or restricts the overall level of care of an ESRD patient is a health barrier or a health inequity. So again, that can be transportation, that could be limited dental coverage, that could be health literacy, limited medical insurance, limitations and referrals to specialty care, their home environment, their socioeconomic status, a lack of social support. It can be a variety of things that have nothing to do with race, ethnicity, or disenfranchisement. Next slide. So now we're going to switch gears and talk about patient engagement. Next slide. And here I'm going to talk about the Patient Facility Representative Alliance, or known as the PFR Alliance. And this is just a group that provides opportunities for patients, transplant recipients, and care partners to really support their facility in the promotion of patient-centered care and quality improvement activities. Really, the PFRs or the patients are going to act like a bridge. They're going to represent their ESRD peers. They're going to bring problems to the facility. They're going to collaborate with the professional staff in order to make sure that patients are understanding the different types of treatment modalities. They're going to bring different educational topics to the patients, and they're just going to really help to make sure that some of these patients are compliant. So facilities who are working on quality improvement activities will have to have at least one PFR to assist in their quality improvement interventions and activities in the facility. So we have 3 levels of engagement. The first one is PFR members, and these are individuals who are really just starting to become activated in their treatment. They're really just looking to engage in passive engagement. They're maybe looking to just send out different resources that they receive from the network. Maybe they'll give it to their social worker, or maybe they'll help with huddle boards. Then we have QIA champions. And these are the individuals that are really going to assist with the intervention on the facility level. They're going to collaborate with their social workers. They're going to collaborate with their medical team. They may do lobby days. They're really going to help with the distribution of resources that are received from IPRO Learn and kind of help push a lot of these interventions. And then we have our patient subject matter experts. These are our long-term ESRD members. These are the individuals who are participating on a national scale, doing community-based interventions and things like that. Next slide. So there are ideal patients to serve as a PFR. These are patients who really desire to have a positive impact on their patients and the care their patients are receiving. They really desire to be a part of a group, or their desire to make an impact on something that's bigger than themselves. These are individuals that have the ability to connect with other patients. They are showing leadership ability, and they're available to listen and support and guide fellow patients. But it's also important that they're very compliant with their treatment. And if you have a patient that would be a good PFR, please fill out the application. There is the link below. Next slide. So there are different ways of engaging your PFR. So one of the first ways you can engage your PFR is having them assist you in the distribution of patient educational materials, having them help you design huddle boards based on specific topics. 1 week it could be transplant, another week it could be home dialysis. You also want to invite your PFR to the QAPI meetings to report on their progress of their work, some of the successes they've had, some of the challenges that they've had. And you also want to discuss with your PFR if they're interested in becoming a peer mentor. So it's also important to remind their patients that we do have monthly PFR meetings. They occur every first Thursday of the month from 5:30 to 7 p.m. and our next meeting is November 3rd. Next slide. So we also have social media. The network has created a Facebook group that is created specifically for our PFR Alliance members, and this is where they kind of talk about different things. They share different events. They talk about different strategies that they've used, and they just really share overall general knowledge with one another. And then we have our Twitter page, as well as our LinkedIn and our Instagram. Next slide. It's also important to note that as you guys are working on a lot of your health equity projects in IPRO Learn, it's important to note that these projects have health equity really embedded in them. And as you come across different barriers, whether it be for transplant, whether it be for vaccination, it's important to let your project lead know, because if you let us know, then we can create resources to kind of help mitigate some of these issues.
Danielle, we did have a couple questions coming up in
Sure,
chat.
go ahead.
So one of them was, are PFRs still required to do peer mentorship training?
So their PFRs are not required to do peer mentorship training as if they are interested in doing peer mentorship training. And it's really up to the discretion of the facility if they think that their PFR has the ability to be a peer mentor.
And then the other question was where they could find more information to more truly understand the role of the PFR.
So it is on our website. We have a breakdown of the different roles on our ESRD website. I can put the link in the chat.
And then they say, do patients have to have computer access to act as a PFR?
So no, so we do our meetings via WebEx, and we have a lot of people call in because we do know that some of these patients do struggle with technology. So our WebEx is, and even if they're interested in peer mentoring, they can access all of these things by phone. We can also print out the meetings information for them, as well as including the slides and things like that if they do struggle.
You might also want to include the link for the PFR application, Danielle.
I'll include that in the chat.
Somebody else is asking about that. So I think I think the information that you would share about being a PFR would really help, because I have 2 questions on that. And then how to like apply is the other questions. Yeah, and people are saying maybe 5:30 doesn't work.
Yeah, so we are open to the idea of changing or having 2 meetings if necessary. We do know that that time frame doesn't necessarily work for all patients, so we are considering having it one on Thursday and another one on Wednesday, but Wednesday at an earlier time. So that is in talks. We're in talks.
And then the last question is just to give a little overview, like once they sign a person up to be a PFR, how do we communicate back with the patient? You could maybe explain that.
So the patients should start once they complete the application, they are immediately added to our email list. Then they start getting emails from us. So that's going to consist of newsletters. The newsletter is going to have like a little welcome message at the top. So that way they identify that it's the PFR Alliance. They'll also receive a welcome email, and they'll also receive text messages from us as well. Now, if they're not receiving their emails, we want to make sure that they're checking their spam account. We also want to make sure that they're searching my name, Danielle Andrews, or IPRO ESRD Network. Because sometimes they miss it because they're looking for the word PFR Alliance instead of my name or the program's name.
And I think it's important to also note, right, Danielle, that the application is not only just the application, but also that the signature part where they have to kind of sign that disclaimer.
Yes.
So both of those have to be in for us to like have them
Yes.
on the list to work with them. So, all right. Well, thank you everybody for asking some questions. I do want to remind those people. Now we'll give you the link. We don't really fax PFR agreements anymore. So Daniel will be
We
dropping this.
can fax it through, if absolutely not, that has to be the last resort. If you reach out to me and say you can't email it to me, we can do a fax
I
through
think
ring
she's
transfer.
wanting the PFR form, Danielle. So I'm just gonna. I think the link would be more helpful, right? To print
Okay,
it.
yeah, the link would be better. It's on. I'll send it now.
All right, so we are going to move on to the second half of the meeting. And in the second half, you're actually going to break out and go to a session with the quality improvement lead who's in charge of that work. So transplant, home, hospitalization, depression, and they're going to go over the specifics of the work that they are doing, what the goals are that they're, that CMS wants us to achieve, and some of the resources and approaches that they've taken to work with the coalitions in the past and work with you going forward. I do want to remind everybody that if you are a call-in user, we cannot move you to a breakout session. So anybody who's a call-in user that cannot switch to getting on their mobile app or onto a computer will not be able to move over to the breakout, and we'll just have to get slides later to get that information. So we do apologize, but it's very important for us to be able to split off that you're actually in the app to do that. And if you have problems right now and you stay on, we will try to help you get to your breakout. So if you don't automatically move to a breakout, we will be on and people can help you get over to that breakout. What will happen right now is in a couple minutes, as soon as I give the notice to Laura, they'll turn it over to the breakout sessions. People will automatically, if you signed up, will automatically shuffle you to the appropriate breakout, and you'll come up in another room, and you'll start a dialogue with the QIA lead for the IPRO ESRD program. So just give it a second or two and that will restart. Once you're done in that